go. Okay. Hello, YouTube. I'm just getting Facebook started here. Hi, guys. Hi, YouTube. Hey, listen, I'm trying to get Facebook started. And my Comcast is really weird. How's the sound? How's the sound on YouTube? You know. All right, we're gonna give this a try on Facebook. All right, you guys on YouTube. What did I screw you up in some way? You never know. All right. Hi, Deborah. Can you hear? How is the sound, hon? How is the sound on YouTube? We're just getting things set up here. Ah, the joys of technology, right? Right. All right. Hi, Julianne. Hello. So, Deborah, how is the sound on YouTube? All right. Hi, Joan. It's May, the lovely month of May. That's from Camelot. Let's see. Blissfully astray, tra-la, it's here, the lovely time of year. Camelot, my favorite live show. Let me grab this. All righty then. Okay, good. The sound is good there. The sound is good here. Hello, Sue. How are you doing today? So now that I've done my little setup thing, let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I am the longest serving IC support group leader in the United States and am now the national IC support group leader doing these meetings. And my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody to be able to minimize you or demean you or tell you that it's all in your head, which happened last week again with a patient. Drives me absolutely crazy. Absolutely crazy. Hi, Jeannie. Hello. Nice to see you. Hi, Cara. Nice to see you guys on Facebook. If you could share this in your groups, that would be great. Normally, I'll do these meetings for a couple of hours. We've gone as long as 5 hours. We've gone as short as an hour. So let's see. I did hear fire engines just about 10 minutes ago. So you never know what's going to happen here in the lovely state of California. Hold on, something on my glasses. Normally when I do these meetings, I do a bit of a 30-minute intro, some sort of educational material, because again, my job here is to try to educate you, and then I'm happy to take your questions, etc., etc. We'll just go as long as you want to go. It's a beautiful Sunday, and I hope that you can get outside and enjoy this lovely day. Hello, Debbie. It's very, very nice to see you guys. If there's any topics you want me to talk about, please don't hesitate to ask, because I am willing to talk just about anything, as you know. Love to do it. So one of the things that's very, very important to me right now is that we really focus on the concept, well, hope. Hello, hope, right? I mean, I need you to understand that 20 years ago, we all believed IC was an incurable bladder disease. We don't think that anymore. We think of IC as a pelvic pain syndrome. Why? Because structures outside of the bladder are often involved. And so for those of you who you have a normal bladder, or you're doing bladder therapies and you're not getting better, this is the time to stop, take a step back, revisit the diagnosis, and let's make sure we haven't missed something. That's what the American Urology Association says you're supposed to do. You give a treatment a reasonable period of time to work, and if you're not getting better, then hey, man, let's not continue to do that for 20 years. Let's make sure we haven't missed something else that could be treated. And so, basically, Deborah moved to Facebook. Was YouTube being weird, hon? We have this whole new horizon ahead of us now. Now, for those of you who are really struggling, this is where we're actually finding cures for some of you, for many of you, actually. Understand, too, that I don't really want you to think of IC as a disease. I want you to think of IC as injury, because as we look at our subtypes for IC, right, we have, and I use the Chris Payne subtyping system. So we have 5 fundamental variants in the IC patient community, although I think we should say 6 right now. So number 1, Hunner's lesions. Number 2, bladder wall driven. Number 3, pelvic floor driven. Number 4, pudendal neuralgia. Number 5, central sensitization. And number 6, I do think we need to have a new subtype for autoimmune cystitis for those patients who have lupus and Sjogren's. But that's going to be a really, really, really small group of patients, like literally 3 to 5%. I don't know what's going on with YouTube here. Well, anyway, it is what it is. So, whenever I'm working with patients on the phone, one of the ways I always end my conversations, almost always in my conversations, and believe me, I'm being absolutely truthful, is for the great majority of you that I work with, there's nothing about your case that scares me in any way. And I think we walk into this diagnosis and into the living with pain so scared and frightened. I thought that I was dying. Literally, I thought that I was dying my first year. And the doctors were just saying incurable bladder disease. And yet everything that we did for me didn't work. Why? Because it turns out my bladder's normal and healthy. They did 2 cystos back then. My bladder was normal. And yet they continued to do bladder therapies. And this is where Western medicine fails the typical bladder and pelvic pain patient. And I'm referring specifically to this book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. He's the one that says this. Western medicine fails the typical IC patient because doctors stay in their sandbox. Urologists stay in the urinary tract, gastroenterologists stay in the bowel, gynecologists stay in the reproductive system, and they don't look at how structures influence each other. And this is what we know now. This is what we know to look for, is how different things are influencing the behavior of the bladder. And when you think about the pelvic cavity, right, your pelvic cavity goes basically from hip bone to hip bone, from the top of your hips down to your tailbone, right? So it is a fairly small confined area, and there's a lot happening in this area. We have skeletal muscles that help you walk and move your legs and jump and all that sort of stuff. We have got blood vessels, large blood vessels that come through the pelvis and go down into the legs. We've got nerves, including a very large femoral nerve that goes through the pelvis and down through the legs. I know this because I have a femoral nerve injury, which sucks. And then, of course, we've got big structures. We've got the bladder. We've got, for women, uterus and the vagina, et cetera, et cetera. And so, as Dr. Weiss very correctly says in this book, is nothing operates in isolation in the pelvis. The bladder does not operate in isolation. There's a tremendous amount of influence. If, for example, you have a fibroid tumor pushing on your bladder, that's going to trigger symptoms of frequency, urgency, pressure, pain. If you have endometriosis attached to your bladder, that's going to trigger the same symptoms. If you have a Tarlov cyst off of your spinal cord, that's a possibility. If you have a broken tailbone that has pushed your tailbone to the left or to the right, or just basically out of place, that can trigger all of these symptoms. If you have a history of pelvic trauma, that can trigger all these symptoms. If you have an underlying muscle dysfunction, that can trigger these symptoms. If you have one leg longer than the other, that will eventually trigger these symptoms. Something called, okay, here's your two scientific words for the day. The first one is the viscerosomatic reflex. Viscero standing for organs, somatic standing for muscle. So the viscerosomatic reflex. So basically what that's saying is, can an organ change muscle behavior? And the answer is absolutely. If you're in pain, your muscles are going to get tight to protect you from that pain. So if you, for example, are going through chemotherapy, or you drank a lot of cranberry juice or something or coffee or diet soda or whatever, your bladder was not designed for coffee. Your bladder was designed at the latest 5,000 years ago with evolutionary adaptation. In fact, tens of thousands of years before. That today's acid load and irritation load on the bladder is phenomenal. And in many cases, it exceeds our bladder's ability to be healthy. So here you're pouring, let's just say you're doing a massive amount of diet soda. You do it as a teenager, you do it in your 20s, and then bam, in your 30s, it gets you. Why? Because eventually you've defeated the bladder's defenses. You've damaged the bladder to the point that the bladder is now being injured by that acid and by that irritation. And because you're injured, your muscles are going to get tight to protect you. Anytime you're in pain, your spinal cord sends to that area a message to stop, don't move, it hurts, right? So when you have bladder pain, your pelvic floor muscles are going to be tight. You can't stop that. That's just the way the central nervous system works. So our therapeutic priority for that bladder wall injury patient is to calm and soothe the bladder. If we calm and soothe the bladder, the muscles should eventually release, hopefully. Unless it's been going on for years, and then you're probably going to need some muscle therapy, right? So that's one very clear subset of you. But the larger subset of you is not the direct bladder wall injury patient, it's the pelvic floor injury patient. So I was working with a patient last week who, gosh, God, there's so many of you now. Gosh, what was she? Was she a dancer? Anyway, it was very, very clear that she had a history of pelvic traumas, starting with gymnastics when she was younger. And then she had a couple of children, and one of the deliveries went very bad. She had massive damage. They had to surgically repair her. So we've got trauma after trauma after trauma after trauma to the pelvic cavity. And I think she even had like a tailbone or something like that. I mean, it was a like this poor lady literally just had way too many pelvic traumas, and it was taking a toll. But of course, you have no idea you really had a pelvic trauma. You don't understand. They don't naturally train us to understand that the bladder is going to be involved. But your first symptoms are frequency, urgency, and you immediately assume you have UTI. Of course, you think you have UTI because you have all the symptoms of UTI. You call your doctor. You say, "Hey, doc, I think I have a bladder infection." You get the antibiotics, you take them, they don't work. You go back to the doctor, say, "Hey, it's still here," or "It's come back." It's a month later. The doctor goes, "All right, let's put you on some long-term antibiotic." That doesn't work. You go back to the doctor goes, "Okay, well, I think you have overactive bladder," and they give you overactive bladder meds or prostatitis meds if you're a man. Those don't work. You go back to the doctor, it might be 6 months later, a year later, 2 years later, and you're still having quote unquote flares, and the doctor gives you I hate to break it to you, I think you've got this rare bladder disease called interstitial cystitis. It's incurable. I'm sorry. Here's the diet. Here's some Elmeron. I'll see you in 6 months. And you're a good girl. You want to do it. You want to get better. So you go home and you follow the diet to a T. You take your medications to a T. The problem is you keep flaring. Why? Because bladder treatments are not going to fix the underlying problem for the patient with the muscle injury. Understand that for the last 100 years, you look at IC research studies, they describe muscles so tight they resemble piano strings. Urologists have known this for 100 years, but they didn't do anything about it. They focused just on bladder therapies. Today, it's a very different story. Now we know those tight pelvic floor muscles are a sign. We know that the legacy of those tight pelvic floor muscles is ischemia, which is oxygen deprivation, nutritional deprivation to any of the organs in the pelvis because the muscles are so tight, they're squeezing blood vessels, right? So our therapeutic priority for this injury patient is not bladder treatment. It is, in fact, to restore blood supply. We have to get the blood flowing. We've got to get good oxygenation to those tissues again. Okay, so how are we going to do that? We're going to do that with pelvic floor physical therapy. Pelvic floor physical therapy is stunningly successful. It is stunningly successful. So I look back at my life, all the bladder therapies I did, DMSO, various, oh man, I must have did 4 or 5 antidepressants. I did the antihistamines. I did a couple of supplements. And in the end, nothing fixed me like pelvic floor muscle therapy. Pelvic floor muscle therapy gave me my life back. I don't live with constant pain anymore. I don't. And that's because we recognize the underlying problem. And the underlying problem for me was, in fact, my muscles. So I want you, for those of you who are not getting better on bladder therapy, let's kind of take that as a good sign in a way, because what that means then is maybe it's not your bladder, maybe it's something beyond your bladder. We have to start looking beyond the bladder. Debbie, having knee surgery tomorrow, you got vulvodynia. So Debbie, wow, honey, yeah. So she also has vulvodynia. Is this really acting up? Understand, hon, that when you're distressed and you're getting ready for knee surgery tomorrow is absolutely stress. So what happens is that stress causes you to tighten your muscles, and you've got levator ana muscles directly above the above the vulva. And so it's probably that stress that's triggering your vulvodynia. I think anything that you can do, maybe use a heating pad, do some relaxation, go sit in the sunshine, just try to mellow out a little bit and try to calm everything down would be really good. Barbara, hello, Barbara. She said I had a slightly different diet this weekend on a short trip and I'm suffering with extreme pressure and burning. I've been on the elimination diet for 5 months. Well, what'd you eat, Barb? What'd you eat? I'd love to hear. Because we all have to share our mistakes. I mean, like, seriously, probably... let's see. When I think of the flares that I've had, that I used to have all the time, I wrote a blog called "Anatomy of an Utterly Ridiculous IC Flare." This was my first or my second year. I had like, oh gosh, like a smoothie in the morning with orange juice or pineapple juice, and then I had a burrito for lunch with spicy salsa. And then I did something else for dinner, and it was just like utterly ridiculous. I had a terrible flare because I didn't really understand diet back then. You know, a lot of people ask, why does somebody with a muscle issue have diet sensitivity? And the answer is because your bladder, if your bladder wall is being deprived of oxygenation and good nutrition, it's not going to be healthy. You know, if your bladder is supposed to get 24 units of blood a day and it's only getting 10 units of blood a day, it's not going to be good, healthy, resilient tissue. And that's why you eventually end up with some bladder sensitivity. Hi, Barbara. I'm good. You know, things have calmed down. Mom is stable. That is the important point. Joan says, have you heard that COVID could cause a flare-up? Yes, honey, yes. I built a whole website on that. It's called covidcystitis.org. We certainly know, she says, I'm at the tail end of having COVID and now having frequency and burning when urinating. This is classic COVID cystitis. We have been studying this for, almost 2 years now in IC patients. I have a research study on our website because I see patients were reporting having more intense flares and flares that were not responding to their typical flare management tips. And that's, we think, is that massive cytokine inflammatory storm that not only damages the bladder, but it reaches the urinary tract and damages the urinary tract as well. So if you're looking for tips on that, go over to covidcystitis.org. Rebecca says, I thought I was dying. I asked my friend if she thought I was dying. I was convinced. I was completely and totally convinced that I was dying of cancer my first year. Absolutely. I didn't believe them when they said that it was my bladder. I did not believe them. And so much so, because the pain was so bad back then, that I basically slept on my living room floor in the fetal position. I stayed away from my bedroom because I didn't want anybody to hear me crying. And I didn't flush the toilet all night, even though I was peeing every 20 minutes on those really, really bad nights. And so it was my worry was such to the point that I actually demanded exploratory surgery. And I had a laparoscopy to look for tumors and stuff in my pelvis in September of 1993. And I kind of needed that in a way because I was so obsessed with this idea of cancer, that I must be dying of cancer, that nothing else would have deterred me. Now, today, we have something called a urine cytology test. And you just pee in a cup and they send it off and they'll look for cancer markers. So if you have a worry that there could be cancer, especially if you were a smoker, then just ask for a urine cytology test. And I'm going to bet you they've already done it anyway. That's part of the normal diagnostic workup before a diagnosis of IC. So I take it from somebody who's been there. You really don't have to worry about a connection between IC and cancer. Barbara says, this is what started it for me. I've been suffering for 5 months since COVID. Yeah, honey, that COVID cystitis. So we've got 3 theories as to what's happening with COVID and why that's irritating the bladder. Number 1, the cytokine storm. Number 2, maybe active virus actually living in your bladder wall, because we now know that happens in the bowel in some people. And number 3, some neuroinflammation, again, from damage that the virus has caused. The sense that I'm getting from patients that I'm working with is that it tends to last between 3 and 6 months. And so, Barbara, if you can just follow the diet, try to protect your bladder, maybe look at using something like Allopath to kind of calm and soothe the bladder, Peora to try to reduce some of that nerve pain. That might be reasonable to try. I wish that we had a published peer-reviewed protocol for COVID cystitis. We don't. Over on the covidcystitis.org website, what I did is I took the suggested treatments from all the papers and I combined them in one document so that you can at least see that. Joan said she also got a flare after the COVID vaccine. We don't have, we just don't have data on that. I mean, I'm going to be perfectly honest here. When I did our COVID cystitis survey, I did not include the vaccine in that. Number 1, because we didn't have a lot of controversy around the vaccine back then. We were trying to save lives. And then number 2, as time went on, I didn't want to be the person who convinced somebody not to get the vaccine. Because you have to outweigh the risks and benefits of the vaccine versus actually getting COVID. And I just was extremely uncomfortable going there. That's an individual discussion that you have to have with your doctors. Kayleen says, I feel like I'm dying every time I have a normal pee and bowel movement. I'm so sick. 18 days, girl. 18 days before surgery for Kayleen. May we have a hallelujah for Kayleen and some extra prayer. She is being very patient, waiting for the care that she absolutely needs and deserves. Kayleen, you got this. 18 days. And she says, I have physical therapy on Tuesday. I don't even think I'm ready for that. You know what, girl, you can do anything. You can do anything. You can do that PT. you got to be a vocal participant, let them know what feels good and what doesn't feel good. Shira says, but what about girls that their onset was infection? And what about the possibility of embedded UTI? Absolutely. I think that there's absolutely a small subset of patients who do have chronic UTI or embedded infection. The chronic UTI patients are really probably going to be the estrogen atrophy patients. So if you've had a hysterectomy or you're on Lupron, chemical menopause, or you happen to be over the age of like 45, that loss of estrogen makes your bladder more vulnerable. And there is very clearly a group of women who get recurring bladder infection associated with the loss of estrogen. Embedded UTI is an old theory that's been around for well over 25 years. It has been debated, talked about, you name it. It's all happened in the last 25 years. It's rather like the Democrats versus the Republicans right now. It's a very hostile debate, tragically. What our National Institutes of Health continues to find, though, is not embedded bacterial infection. It's finding chronic fungal infection. And it was about 5 years ago that the MAP Research Network, which is the multidisciplinary approach for the study of pelvic pain, that is our United States-based IC group. And it is a massive team of researchers from around the country trying to understand why a urologic chronic pelvic pain occurs. And that includes interstitial cystitis and chronic prostatitis. Now, they were the ones 5 years ago who made a rather startling discovery, and that is that many patients who were flaring with bladder pain were flaring because they had fungus in their urine. They had candida in their urine. And the problem is you have all the symptoms of infection, frequency, urgency, pressure, pain. I can tell you from firsthand experience that candida in the bladder is very, very painful. And you go to the doctor for a urine test, it doesn't test for fungus. They do not test for fungus. That's why we really like the next generation DNA urine test, because it will test for fungal infection. Now, UCLA, about 4 or 5 months ago, they released their own study, where they too very clearly identified chronic fungal infection in patients with bladder pain. Only they went down to study the actual candida, and what they found was that it was very virulent. It's an unusually damaging candida infection in the bladder. So I'm open to the concept of chronic UTI, but I am expanding your horizons to go look past bacteria and look for fungus and possibly even virus, because we now know, again, from Europe is often the leader here in research. They're the ones who found the polyoma virus first in the urine of patients with Hunner's lesions. And again, 5 years later, our own MAP Research Network confirmed that a small subset of IC patients do have chronic virus in their bladder. And that is what's happening also with COVID. Some patients who get COVID have viral infection in their bladder wall. How do we know that? Because we find live living virus in urine of some, but not all COVID patients. Generally, it is the patients with the most severe aggressive COVID who get living virus in their urine. But I think even like 4 months, if I remember correctly, there was a study that showed that like 4 months later, they were still finding live virus in urine, in stool, and I think in semen. So we're learning a lot about, we're just at the beginning of learning about, the long-term ramifications of COVID. It's devastating. You guys all saw, hopefully you all saw that we now know the cause of MS, right? The cause of MS is the mononucleosis virus. My first love, my college love, who I should have married. We would have been perfect together. And we were in pharmacology together. And he had really aggressive MS. to the point that every weekend he was flying up to Stanford for experimental treatment, and it was going up his shoulder and into his heart. And so when we graduated, he broke up with me because he said he didn't want me to watch him die, and he was very sincere about it. Oh, but now we know what that's caused by, and that is for some patients caused by getting mononucleosis. So now we have potentially new treatments too, maybe. We'll see. All right, hold on a sec. Facebook, let me scroll Facebook. Yvonne says, I believe mine is both. Which came first? Who knows? Now my bladder is damaged and tiny. Is there any hope? There's always hope, girl. There is always hope. Well, we really want to try to make sure that we're covering all the bases. I mean, if you've got tight pelvic floor muscles, you got to work on those muscles. If you've got some direct bladder wall damage, we've got to work on that. You've got to protect your bladder massively. We got to calm the nerves down, et cetera, et cetera. It's not a one treatment fits all approach, and it's not like one treatment's going to fix everything. There are multiple things happening here that they all have to be addressed. Tabitha said, I have Ic and Sjogren, so my urogynecologist said atrophy, so I use estradiol, but I still have terrible external itchiness and irritation. I think I heard you mention a correlation between Ic and Sjogren. I never heard that. Yeah, honey, that's a well-known. You go back some of the earliest research studies back in the early 1990s. They found that I think 3%, maybe 3 to 5%, more like 3% of Ic patients had Sjogren's and or lupus, and now we call that autoimmune driven cystitis. The fact that you're still having terrible external itchiness and irritation is concerning. Understand that estrogen cream, especially brand names like Premarin and Estradiol, often have a lot of extra preservatives in it to expand shelf life. And so it's not unusual for a patient to be doing either one of those to experience extra irritation. That's why we usually suggest doing a compounded preservative-free estrogen cream, because there's no preservatives in it that might be as irritating. We also really would want to make sure that we've ruled out other things that can be going on down there, right? So I sent out an email like 2 months ago to some of the top doctors in the world, and I said, what is our treatment priority for autoimmune cystitis? And they haven't talked about it enough to have a plan, in my opinion. Judy said, what's the connection between interstitial cystitis and SIBO? What we have been doing for about the last 10 years are biome studies, trying to understand the normal healthy biome and how that differs in patients with IC. And what we continue to find in those research studies is that the urinary biome of an IC patient is different than a healthy person, that we have more bacteria that tend to be a little bit more pathogenic and less of the bacteria that is supposed to be helpful. We don't have enough long-term data to make any good conclusions on what the right thing to do is, but that's why Bladder Builder, which in my opinion is the top supplement on the market right now, has beneficial probiotics in it. I did a big blog on it on our website, and there's like something ringing at me that I should be saying with this. It'll come to me eventually. Just understand that as we ponder the entirety of our body, we ponder systemic effects in our body and what influences what. The core fundamental foundation of our body is, in fact, having a good biome. It means having good bacteria in your body. That having bad bacteria in your body or an imbalance can lead to all sorts of other issues, including brain issues. Hi, Mary. I just put a new blog up on my Twitter feed about the influence bacteria in the bowel and how that changes the brain. So Sue says, what about hyperbaric therapy? Hyperbaric therapy has been found to be successful for patients with Hunner's lesions. You can find that data on our website. I did a blog on it, so go into our blogs and look under hyperbaric. It was probably 18 months ago. Linda said, I'm having back surgery Wednesday. Last time I had it in August, I flared so bad the ride home was torture. Any suggestions? Pain medicine for the ride home, hun. Hopefully they're giving you a good amount of pain medicine to get yourself home, right? If you can lay on your back seat, that would be great. It's about finding the right position for your back and minimizing trauma to your pelvic floor. There's a part of me that says a muscle relaxant might be quite helpful to keep those muscles from getting tight. But the problem is you can't mix muscle relaxants with pain meds. So you got to be really careful about that. And so, there can be dire consequences if you start mixing muscle relaxants and pain meds. So I think you need to let your doctor, you're concerned, tell them how bad it was the last time, that it was torture, and see if they'll give you a stronger pain med to get home, like a shot as you're walking out the door. Kayleen says, I have endometriosis. It is blown right now and a uterine polyp. I'm having a colposcopy, IUD insertion, laparoscopy, and pulpectomy all at the same time. Girl. Amazing. Kayleen says, do I apply ice or heat for this pelvic fatigue that I have right now? I don't know. I think you're just going to have to try it and see which one works for you the best, hon, which feels good. Debbie, thank you so much for the 100 stars. Sandra said, you had a doctor tell you that you had cancer and bladder cancer. So they did a biopsy and they found that you had bladder cancer. Anissa said, is it normal to have constipation with IC? It is normal to have constipation with tight pelvic floor muscles. Linda said, my pain is at the start of trying to urinate. It is very painful. I have to push to urinate and get by the pain. The stream is not painful until the end. The urogynecologist said it was spasms. You've been on the elimination diet for 5 months. It has helped tremendously, but I seem to have flares every couple of weeks. So Linda, what you're saying is are you having pain as urine is just coming into your urethra? Because we would be looking at estrogen atrophy. The urethra is kind of the canary in the coal mine when it comes to estrogen atrophy. And so that could be one reason why you're having so much urethral pain as you're trying to urinate. The other thing, though, is pushing. When you push, you are defeating your natural pelvic floor tone. Urination is about relaxation. Normally, you sit on the toilet, a muscle relaxes, a sphincter opens, and you pee right away. If you can't pee right away, that means your muscles are locked down and tight in many, many cases. And so here your muscles are tight. They're restricting your ability to pee. And what are you doing? You're tightening them and making them worse. Very important not to strain when you're urinating. I think it'd be really interesting for you to have a pelvic floor assessment and let's see what's going on with your muscles. Joan said, is there any info that COVID can cause UTI? COVID absolutely can cause live virus in the bladder wall. Go over to covidcystitis.org. I have all the research studies over there. Shira says, does Microgen test for viral infection? You would have to call them to see if they did or not. I know that they've been doing a lot of COVID testing. And so if they're testing for the COVID virus, then clearly they have the ability to do that. But whether that's built into their normal bladder panel is another story. I think you would have to call them and find out. If they won't do it, there is another company that normally does it, and their name starts with an A. What is their name? It'll come to me. Just Google next generation DNA urine test. A periomics. I think it's a periomics. Aperiomics, Aperiomics. Denise says, I've been taking estradiol cream for like 11 months now, having UTI and IC from genitourinary syndrome of menopause. You've been doing great, but this last week I had a huge flare, lasted just a day, thank God, and now I have burning inside again. Do I lessen the cream or increase? Am I taking only increase? I am taking only half a dose recommended by your doctor. Well, I think you need to follow your doctor's recommendation. Your doctor said to use a specific dose. You try it. If you've cut it down by half, you're now limiting your bladder's ability to produce mucus. It needs estrogen to produce mucus. Dave said, my discomfort and pain seems most often linked to fullness in my bladder. You just can't find that Goldilocks zone. I hear you. So, all about the bladder wall then. Let's do everything we can to try to help the bladder wall. Now, guys, now seriously. Some of you have called me recently. One woman in particular, I always have these memorable conversations. I spent probably an hour with her on the phone. And we're going over the different subtypes, bladder wall, pelvic floor, yada, yada. She was of a certain age. She was really struggling with symptoms, like really badly struggling with symptoms. And yet again, it's like finding a needle in a haystack. It's like, are you following the diet? She goes, yes. And I'm like, really? And she goes, well, you caught me. And I'm like, what? Yeah, I am addicted to Coke. I'm like, oh. How much Coke are you drinking a day? 3 Cokes a day. No wonder she couldn't sleep. No wonder. Here she is. She's got clear estrogen atrophy. She's of that age. Her bladder wall cannot protect itself. Everybody's told her to stop drinking the Coke. She couldn't do it. And once I explained the pepperoni pizza thing or the pizza thing and how one Coke, well, let me just take that back. The bladder wall is composed of the largest single cells in the human body. Okay. And if you look at it under an electron microscope, it looks like a beehive. They're hexagons. We call these umbrella cells, right? So I want you to imagine a giant pizza, an extra large pizza, and then one little tiny green pea underneath that pizza. That little green pea is the stem cell. So when the pizza is damaged, when the umbrella cell is damaged, that little tiny cell takes 2 weeks to grow and expand and change shape and become the new umbrella cell. But we know that while it is in the growing process, it is exquisitely vulnerable to acid. Literally one soda or one coffee will destroy it. So if you're an IC subtype 2 bladder wall driven and you're trying to help your bladder heal, you have to understand as long as you're drinking coffee or soda, even one a day, even one decaf a day, I'm sorry, you're never going to get better because you're literally interfering with the healing process. It's every soda sets you back 2 weeks worth of healing. So I said that to her and she was shocked. And it's like, that's why you have to stop. And she goes, nobody ever explained it that way. And it's like 3 months, 6 months, follow the diet, give your bladder plenty of time to heal, use that estrogen. Let's help that bladder produce a bit more mucus, help that urethra produce a bit more mucus, get healthier again. And then maybe we'll try again, but rather than with a brand name soda, maybe do an Italian soda to start with. Ruth says, can IC have a link to speckling at the back of the eye? I have both symptoms, not the IC, the Elmeron. Did you use Elmeron, hun? Elmeron is now linked to the cells in the retina changing color. We call it pigmentary maculopathy. So Ruth, did you take Elmeron? Anissa says, where do you get Bladder Builder? On our website, huh? Just go into our store on the IC Network website, icnetwork.org. No space in there, icnetwork.org. Anissa says, what supplement for constipation with IC? Well, okay. So I just did a huge article on constipation in our last newsletter. Number one, with constipation, seriously, we've got to get our fiber intake up. You have to eat a minimum of 20 grams of fiber a day to be healthy, to have normal, healthy bowel movements. And I've shared, I have no shame. I will share anything. So about 10 years ago, maybe 12 years ago, I was really struggling with rectal pain, very, very severe rectal pain. And it was like passing hard rocks. My stool was very hard and painful. And whenever it was in my rectum, it was killing me. And the best, literally the single best doctor's appointment in my entire life was with the IBS specialist. And I'm in there crying, going, please help me. My rectum is on fire. And she goes, yeah, you got a little tiny hemorrhoid on the inside, and it's clearly right on top of a nerve. So that's why you're hurting so bad. But that's nothing. I mean, it's tiny. We would never treat this. It's the size of a sunflower seed. It's tiny. What we have to treat is the thing that's pushing it, which is your hard stool. And she said, so Jill, how many grams of fiber do you eat a day? And I went, I have no idea. Nobody's ever asked me that question. And then I said, oh, I'm sure I'm eating plenty of fiber. I eat a really good, healthy diet. And she's like, well, I want you to go home and count. Look at the labels, count it up. You need to have 20 to 25 grams of fiber a day as a woman to have normal bowel movements. For a man, it's 25 to 30 grams of fiber a day. And I'm like, I'm sure it's fine. I'm sure it's fine. She's like, I double dog dare you. Go home and check. So I go home and check. I was eating 6 grams of fiber a day. 6. No wonder bowel movements were challenging. No wonder I was constipated, et cetera, et cetera. So I Googled fiber counts in foods, and I found this fabulous food chart, fiber count from the state of New York. And I started actually counting up my fiber content as I was eating it. And so let's see, today so far, how many grams of fiber I've had today so far? I've had 3. Not enough. I've only had 3 grams of fiber so far today. There was 1 slice of Ezekiel bread because I had eggs and mushrooms, not very much there. Maybe 1 more gram in that. And I haven't done any of my fiber stuff. So you really have to count it up on a daily basis. When you notice your stool getting harder, you got to take a step back and look at it again. Now, that said, what else can you do? We tend to do better with soluble fibers rather than insoluble fibers. Like I never did really well with psyllium. It just always irritated me. IC patients or patients with central sensitization or irritable bowel, we do better with a soluble fiber. Heather's tummy fiber is my favorite, and it's right here. So I usually have a big heaping teaspoon of this in my smoothie or my herbal coffee every day. And so look for something like this, okay? Heather's tummy fiber. And again, you can find this in the IC Network shop. Love it, love it, love it. Also, if you're eating green salads because you think green salads are high in fiber, you are wrong. 1 serving of lettuce is 1 gram of fiber. 1 serving of green peas, which I happen to love, fresh green peas, it is 13 to 16 grams of fiber. So I always make sure that every week I'm eating peas, I'm eating baked beans, anything at all like that if I'm starting to feel a little bit wackadoo down there. Dave says, what kind of doc does a pelvic floor exam on men? A gynecologist? No, it's going to be a certified pelvic floor specialist. And Dave, if you go to pelvicrehab.com, you can search by zip code to find physical therapists who are certified in pelvic health by the Herman Wallace Institute. They have taken a lot of extra courses to get there, and they're the ones who treat men and women. They treat a ton of male athletes. You would not be the only one in there, I promise you. Sandra said the doctor was obviously unaware of IC. Sadly, we get to teach the doctors of IC because a lot of them don't know what it is. That's very, very true. We are the agent of change. We are the educators. We are. We are. Listen, you have to understand how doctors are educated. Number one, IC is really not taught in medical school. And you know, as they're going through medical school and they do their rounds, yes, they might have an internal medicine round, a gynecology round, et cetera, et cetera. There's no round that talks about relationships. There's no round that talks about pelvic conditions and how that affects the bladder and the bowel, et cetera, et cetera. And so, you know, we are at the cusp of a new era in terms of educating more people about why pelvic pain occurs and the many conditions that can contribute to pelvic pain. And there are doctors now that are a couple of doctors in the world who are aggressively advocating for this, who have also created teaching protocols or programs for other medical care providers to help them understand the complexity of this condition. Robert Eckenberg in Bethlehem, Pennsylvania is, I think, our top pelvic pain doctor in the country right now, to be quite honest. Charita says, I have a DMSO treatment. I had a DMSO treatment last week, and my God, I will not do that again if they will not sedate me. As soon as the treatment went in, it all came out. The catheter is so painful. I think it works because I don't have pain ever since, knock on wood. DMSO is an old therapy that has fallen out of favor in part because it can be so painful and or it can cause a garlic-like odor coming out of your pores. Most doctors have moved away from DMSO and they're doing instead what we call a rescue installation. A rescue installation combines heparin and lidocaine. And so you have something to coat your bladder and something to numb your bladder wall. And so it's called a rescue because it rescues you out of a flare. And normally you walk out of the office pain-free. The other thing about DMSO that's important to understand is that we have some data that the FDA-approved dosage of 50% can cause irreversible spasm. Irreversible spasm. And that was presented at 2 American Urology Association annual meetings several years ago. I have links to those studies on our website. DMSO, by consensus at that meeting among the top urologists, they pretty much only recommend its use in what we call a cocktail form, where there's more than just DMSO in there. There's DMSO, maybe there's some solucortef cortisone, maybe there is an antibiotic. I mean, there are a number of things that they can put in there. The goal here is to get that dilution down to about 25% instead of 50%. You can find all that information right on the IC Network website in the bladder installation tab. Bruce says she's not on any meds. Judy says, most people with SIBO can't do a lot of fiber. Yeah, I'm not, I am just not an expert in any way, shape, or form in SIBO. I am sorry to say. All I can tell you is that the biome studies in the IC patient population are interesting. But you know, is that because most of us were given antibiotics for, when we first went to the doctor with these symptoms? If there's one group of patients so completely overexposed to antibiotic use, it's us. And maybe that's why we seem to grow more candida and fungus in our urine. Denise says, Jill, do you feel estradiol cream is safe? My urologist says it is. I'm afraid of heart problems or a blood clot or breast cancer. Denise, if you Google topical estrogen safety, and you look at the studies in the last 5 years, the overwhelming consensus is that it is considered safe, even for patients with a previous history of gynecological cancer. The difference between oral estrogen and topical estrogen is how it gets into the blood supply. When you take it by mouth, it all ends up in your blood supply where it is distributed throughout your body, which is why it's associated with a strong risk of cancer. Ooh, it's a big carpenter bee. Topical estrogen is put on the skin, and it tends to stay in that skin and is not believed to be absorbed into the bloodstream to any great degree. And so I use estradiol cream very confidently myself. I am personally not worried about that. But I am not God. I can't predict the future. I think you have to have a close conversation with your doctor about your past history and your concerns. Rebecca, thank you for the 250 stars. Much, much appreciated. Bernadine says, what kind of herbal coffee do I drink? I drink Dandy Blend. Let me go get it. I'll show it to you. Do I have it here? Let's see. Oh, whoops. Be right back. All right. Sorry about that. I always have to do a visual check of the folks to make sure they're okay. All right, here it is. World's best herbal coffee, in my opinion, Dandy Blend. It's just so good. And you can get that on the IC Network. You know, guys, listen, when I started the IC Network, it was never my intention to sell stuff. It really wasn't. But it was incredibly expensive to do. And all of my savings went into the IC Network. Everything I had got put into our website. And I finally got to the point where I ran out of money, basically, and it had to have its own source of income. And so we started selling books and chair cushions and heating pads and foods and low acid foods and things like that. And then we had our magazine and memberships. And your purchases in our store are very appreciated because it keeps me doing these meetings, right? There's more I could say about that, but I won't go there. Here, hold on. Pamela said, my doctor did that, then told me I would smell for 3 days. Great. I was thankful I wasn't working at the time. I know, right? I think I did 6 or 8 DMSO treatments. Never helped me. Never helped me at all. Of course, now we know why, because it was never my bladder in the first place. It was my pelvic floor. What is this thing on my glasses? What is this? It's like right in the middle. Okay. Oh, come on. Sorry, guys. Okay. Okay. Hi, Becky. Debbie says, I wanted my doctor to order this from the website she gets it at as a hormone, and there could be side effects. My doctor told me to wait on it. Everybody's different. That's true. Kimberly says, my doctor informed me my iron is low and I have to go on iron supplements. Is calcium ascorbate okay to take with iron supplements? My IC is pelvic floor. It should be. I mean, go slow. The iron supplement really should not be an issue with your bladder. I think you're going to just have to try it and see how you do it. My mom does iron every day. It's never flared her. And calcium ascorbate is the buffered vitamin C. And so I would try the iron first for a couple of days before maybe adding the vitamin C to it, so that you be able to figure out which one might be irritating you. If one of them does, maybe talk to your pharmacist about that. And says, my gyno says that when you have a uterus, there's a regimen of how to use estrates. You cannot use it as needed. Is this true? I think it depends upon your age and where you are in menopause, et cetera, et cetera. The problem with estrogen is that the uterus then responds to that estrogen by producing more cells. Think about your periods, and your uterus goes through a monthly cycle to help you have a child, right? And so the uterine layer thickens with estrogen, and then when you don't get pregnant, your estrogen levels drop, your progesterone increases, and bam, you have a period, right? So if you're taking oral estrogen in particular, generally they will also have you do progesterone at the same time. So we're not creating this super, super thick uterine lining that won't come out. Because that's when, especially if it's abnormal cells, it's called complex endometrial hyperplasia with atypia. Those are the cells that potentially could become uterine cancer cells. I mean, that's exactly why I had my hysterectomy for now 5 years ago. 5 years ago this month. Wow. Feels like yesterday. Feels like yesterday. So he's right. The unrestricted use of estrogen can cause consequences to the uterus, and we want to make sure that they're combining that with progesterone. Becky says, I love that you sell stuff. I'm happy to support you, and it helps me know what is a good thing to buy. Yeah, I curate everything. I curate everything in our store. I'm very, very thoughtful about what we do. I try to keep the lowest prices ever because I talk with you every day. And so you'll find, like with the supplements, for example, the supplements on Amazon are like $5 higher than they are in our store. That's why it's always good for you to buy it from our store. Sandra said, I have fulguration and hydro on May 10th and I'm scared to death. Well, Sandra, listen, I think I don't like guessing. I like facts. And there comes a point in time when, if your symptoms are persisting and you're struggling, it's very, very important that you let somebody look. Because we need to know if there's anything else unusual going on there. Do you have a bladder stone in there? Is there anything else that could help us understand why you're having symptoms? And I think that it's important, not only for your physical health, but also your mental health, to let them just look and see what they can find, especially for patients who are bleeding. I mean, like, seriously, if you're passing blood clots, you want somebody to look and figure out what the hell's bleeding. Is it your kidney? Is it a wound in your bladder, et cetera, et cetera? And so I understand your fear about having the hydrodistension and fulguration. There are a couple of things you want to make sure that they're going to do. Number one, it should be a low pressure, short duration hydrodistension. And you need to ask the OBGYN or the urologist who's going to do it, is it going to be high pressure or low pressure? Now, the reason why they put fluid in the bladder is to help them visualize the bladder. Otherwise, sometimes the bladder is like a sack. It's just kind of collapsed up on itself. So generally, when they do a cystoscope, they put fluid in there to kind of open it up a little bit so that they can take a close look at what's in the bladder. And in the old days, and I'm talking like the 40s and the 50s and maybe the 60s, I think, and I could easily be wrong with this, but medicine was very macho and aggressive. And what they found, especially for patients with a lower bladder capacity, is that if they stretched it, like, okay, if the bladder's kind of shrunken, let's stretch it a little bit. And so the way they stretched it is by putting fluid in there under pressure and not letting it drain out. And so they just got more and more aggressive with that. They stretch it more and stretch it more and stretch it more. Then they used high pressure, and then they did it for a long period of time. And eventually, now, Sandra, I'm looking at you. This is not meant to scare you in any way, shape, or form, because it's all changed now. But eventually, back then, they finally put so much fluid in the bladder, they broke the bladder. The bladder ruptured. Okay. But in 2011, when the American Urology Association guidelines came out for IC, they specifically said no longer do any high pressure, long duration hydrodistensions. Our goal here is to minimize trauma. We do not want to do anything aggressive in the bladder that is going to hurt the bladder. So, Sandra, you need to ask your doctor, are you going to do high pressure or low pressure? And if the doctor's going to say high pressure, you're going to say, well, I don't want a high pressure. The American Urology Association guidelines specifically say do not do a high pressure. I want a gentle hydrodistension, low pressure, short duration, which is what I had 5 years ago after my hysterectomy, and it was piece of cake. So they just put a little bit of fluid in the bladder, stretch a little tiny bit, take a look around, do the fulguration, bam, you're done, you're good. The other thing that I would now, I understand that there's a war on pain medication right now. I am appalled that some patients are being sent away from the hospital without any pain care, even after having things like hysterectomy. Are you effing kidding me? No. I would absolutely want and insist on having some pain care for a couple of days. I'm not saying having a month's worth of Vicodin on supply or Norco. I'm saying having maybe a week's worth just in case if you need it. But listen, some patients after hydro, they go out to dinner and they're fine. So that's what we're going to hope for you is they're very gentle. They do what they need to do. Your bladder is mildly traumatized. You might be a little uncomfortable for a couple of days, but bam, it's over, it's done, and life is good. But having a couple of days worth of Norco is not a bad thing on hand. And I think nobody could say, if you ask the doctor for, like 5 days worth of Norco, nobody could ever accuse you of being a drug addict for that, right? But if you ask for 30 days, that's unrealistic because you're not going to need it for 30 days. You might only need it for 24, 48 hours, I wish you well. I truly wish you well. Okay, so I said I was going to read a case study, a couple of case studies. And I wanted to do that. Now, on Thursday, when I did the Facebook support group meeting, I did also read a couple. And I'm gonna do similar ones, okay? So I'm going to do a couple of case studies of men and a couple of case studies of women, okay? And my goal here in sharing you these stories is to help you understand, and as to expand your horizon away from the bladder towards something else, okay? So these are case studies out of this book, Breaking Through Chronic Pelvic Pain. I, again, truly believe this is the best book ever written for the IC patient population. Lorraine's story. Lorraine came to me at the age of 46 with a 22-year history of pain in the tailbone and above her pubic bone. She also had pain in the lower left back that radiated down the side of her leg into her foot, and occasional slowness starting her urinary stream. Her one relatively minor urinary symptom had been previously diagnosed with interstitial cystitis, for which she was treated with DMSO. This inappropriate procedure only served to intensify her symptoms. When I asked Lorraine about tailbone injury, she recollected that when she was 12 years old, her cousin pulled her down a flight of stairs on her back, banging her tailbone on each step. Following this event, she experienced tailbone pain for several months. I postulated that even though the initial pain subsided, The active pelvic muscle trigger points that were causing the pain at the time had merely become asymptomatic but had not disappeared. We call these latent trigger points. What might have reactivated these? Lorraine mentioned that she'd been under extreme stress and was suffering from back pain and constipation at the time of her tailbone and pubic. At the time, her tailbone and pubic pain began again. All of these factors contribute to pelvic muscle tightening and trigger point formation. Collectively, they could certainly have tipped the scale and caused latent trigger points around the tailbone to explode into painful reactivity. My examination substantiated this premise. Her most exquisitely tender trigger points were indeed the coccygeus muscles. I also found tender trigger points and tight muscles around the puborectalis muscles that related to difficult bowel movements. Additionally, there were trigger points around her urinary sphincter that explained the slow start of her urinary stream and orgasmic pain. When compressed, these points referred pain to the pubis, the site of Lorraine's initial complaint. Trigger points in the adductor muscles of the inner thigh and the rectus abdominis muscles of the lower abdomen, as well as tight left piriformis muscle, completed her painful picture. Imagine, Lorraine spent nearly half of her 46 years seeking relief from pain initiated by a tailbone injury when she was 12. The pain that had resurfaced at the age of 24 in response to the contributing factor of extreme stress, which tightened muscles in and around her pelvis, causing back pain and constipation. Along the way, a chorus of trigger points had been forming, and in response to these various assaults, they began crying out in unison for attention. Her treatment included internal and external myofascial release and the injection of particularly stubborn trigger points with an anesthetic solution. This therapy was minimal considering the complexity of her case and the duration of her symptoms. It subdued the angry trigger point chorus, released associated connective tissue restrictions, and gave Lorraine the relief she'd been seeking at last. When it comes to chronic pelvic pain, any long-term sufferer will tell you late is better than never. All right, let's do the big one here. I want to do the big one. Let me get a drink of water first. Hold on. Scott was 24 years old when he came to see me. He'd been suffering for 11 months with rectal, perineal, penile, and scrotal burning, and was finding it difficult to start urination. About 1 month prior to the onset of these symptoms, he became stressed and depressed because of a serious illness in the family. He then began to increase his alcohol consumption and developed intermittent diarrhea. Several red flags surfaced as his earlier history unfolded, including numerous injuries and falls during athletic activities, low back pain beginning around the age of 13, and periodic problems with his left hip that required adjustments when it, quote, went out of place. During my external examination, I found a curvature of the lumbar spine and trigger points in most of the muscles that surround the pelvis. My internal findings were particularly striking. There were active, exquisitely tender trigger points around the urinary sphincter, the urogenital diaphragm, the obturator, piriformis, and puborectalis muscles. And in addition, there was marked sensitivity of both pudendal nerves. After performing myofascial release at the time of Scott's first visit, the pelvic muscle triggers were only mildly tender or not tender at all, and the pudendal nerve sensitivity had disappeared. The fact that the nerves calmed down when the trigger point tenderness decreased indicates that distressed muscles were compressing the nerves. Thus, the muscles were the primary cause of Scott's problems. So how do we put this information together? The first requirement for effective treatment is that we understand why painful muscle trigger points form. This knowledge helps us identify the underlying problem, which in turn helps prevent system persistence and recurrence. In Scott's case, there were many events that might have contributed to overloading the pelvic floor and perineal muscles. I find this with most patients who are suffering from chronic pelvic pain and dysfunction. Then a series of stressors create symptoms that ultimately push affected structures and the patient over the edge. We can look at each stressor or series of stressors as 1 ounce of tea poured into a 3-ounce cup. When you add the 4th ounce, the tea spills out of the cup and symptoms appear. So Ounce number 1. Over the years, this athletic young man sustained many injuries and falls that could stress the muscles of his pelvic floor, perineum, and urogenital diaphragm, creating asymptomatic latent trigger points. The curvature of Scott's lumbar spine could create uneven tension upon and overload many of the muscles that were burdened with trigger points. The piriformis muscle that rotates the hips are a prime example. They attach to the sacrum, which connects to the lumbar spine. Number 3, he had left hip pain, which required adjustments. The external hip rotators pass into the pelvis, and if they are tight and dysfunctional, they can disturb and tighten the neighboring pelvic floor and perineal muscles. They can also directly compress the pudendal nerve. Number 4, severe emotional stress can have a devastating effect on muscles in general. In Scott's case, stress is what appears to have sent the pelvic muscle team into a tailspin. And at this point, latent trigger points that had produced no symptoms for years became active trigger points that were painful and cried out for attention. Stress in the muscles of the anterior and posterior perineal triangles caused the rectal burning, which intensified when those muscles stretched during bowel movements. Stress in the muscles of the perineum between the scrotum and the rectum caused burning in the perineum, scrotum, and penis. Stress in the urinary sphincter and urogenital diaphragm. What's that word? Hold on. Hold on. Stress in the urinary sphincter and urogenital diaphragm tightened the urinary muscles, causing the slow urinary stream and contributing to penile burning. Severe stress worked like an orchestra conductor, increasing the tempo to a painful crescendo. Pudendal nerves joined the chorus of cries, and unfortunately, all of this dissonance disturbed the neighbors, the piriformis, hip adductors, abdominal wall, and gluteal muscles. The result was a pelvis and the owner out of control. I treated Scott using internal myofascial release techniques of compression and stretching to eradicate trigger points and lengthen the muscles. In addition, all of the dysfunctional external pelvic muscles and the restricted subcutaneous tissue received appropriate manual therapy, and after 3 treatments, all of his symptoms had disappeared. So, again, if you haven't responded to therapy and you're getting worse rather than better, you have got to look beyond the bladder. Here, hold on a second. Rebecca says, how come my doctors won't ever give pain meds? Well, because of the opiate crisis, hon. Now, when I was diagnosed in 93, I didn't have pain care for a year. And believe me, I suffered that year. And finally, I ended up at the emergency room 3 days in a row. And they finally gave me, ironic. Come on, hello, degree in pharmacology. I certainly knew about pain meds. I was focusing more on my frequency urgency than the pain, though, right? It just didn't dawn on me that I could use pain meds for this. It honestly didn't dawn on me. And then one day, they actually gave me a shot of Demerol or something like that. And the pain went away. I was gobsmacked. Like, what? You mean we could turn this off? And I was shocked. And that was when they finally gave me a prescription of Vicodin. Now, the thing about pain meds is you have to be very smart about how you're using the pain meds. That patients get into trouble when they start adding more and more. You have a flare. Let's say it's a really bad flare. Maybe I should take 2 instead of 1. An opiate acts at the spinal cord. And you only have a certain number of nerves at the spinal cord. So in my case, I've only taken 1 whole Vicodin once in my life, and it made me very nauseous. And some people would interpret that as an allergy. That wasn't an allergy. It was just too much. And so I cut it in half. I was allowed to cut it in half. I had to score down the middle. And so when I reduced the dose, it reduced the pain, and I didn't get a stomach upset. And then I reduced the dose again to 1/4. And I found that I could take 1/4 of a 5 milligram Vicodin and still get all the pain relief I needed. And I would never look like a drug seeker, that I could make 30 Norcos last 6 months or longer. Nobody could accuse me of that. So that was back in the days when we didn't have the opiate crisis. Today, we have a tragic situation where a couple of drug companies created oxycodone, time release opiates. They said it was safe. They told doctors it was safe. This was back in the 80s and the 90s. And so doctors are like, hey, if it's safe and my patient is in pain, I'm going to give them I'm going to give them oxycodone or OxyContin to help them. Well, it turned out that the company lied, and these pain meds do create, especially the time release synthetic opioids, do create a much greater risk of addiction. So unfortunately, millions and millions and millions and millions of pills were made by the companies. They were sent to sometimes even tiny pharmacies. There was a pharmacy in West Virginia in a town of 300 people. They got doses for like 25,000 people. And all of that went into the drug trade. And so that's then led to this massive addiction problem that we have. Throw in now the synthetic elephant tranquilizers, the fentanyl, and even worse that are coming from China. Fentanyl is so much more devastating. It's so much more dangerous. So many people die from fentanyl overdoses now that, but it also creates a very high risk of addiction. So if you're involved with illegal drugs, the odds are they're going to put fentanyl in it just to make you become an addict more quickly so that you will continue to support the drug cartel. So, we're screwed right now. The other thing that happened is the Center for Disease Control released new opiate guidelines. Then their guidelines were completely misinterpreted. I did a big article on this in I chaired our State of California Pain Conference. So I'm pretty familiar with the details of this. So during, what is it, like 6 years ago, maybe around 6 years ago, the Center for Disease Control, they were charged by the president to help us create a plan to stop all these tragic deaths to oxycodone and fentanyl. And they came up with these guidelines. And these guidelines tragically did not have a chronic pain expert on the committee. The negotiations were all done in secret. Nobody knew who was on the CDC committee. They created these guidelines, and the guidelines had this devastating ripple effect where all of a sudden doctors literally fired patients who were using pain medication appropriately. I mean, if you were going to one doctor over time, using the same amount with no signs of addiction in any way, shape, or form, using the CDC guidelines, they kicked you off of those meds. You then went through withdrawal. And some of these severe pain patients who were forced off of their meds actually turned to the street and turned to heroin instead. And so it's been a shit show. It's been a literal shit show. What a lot of you may not know is the CDC actually issued a statement about that last year or the year before, desperately telling doctors not to do that. Do not take patients off of pain meds who are using them responsibly. But of course, it didn't get the publicity. And of course, many local doctors do not know that the Center for Disease Control rewrote part of these guidelines. So you're in a pickle. You're in a pickle right now. It's very, very difficult. Urologists in general are now very reluctant to prescribe painkiller. Throw in a lot of doctors have been prosecuted, especially the doctors who were involved in the opiate crisis. And so the best way that you can have this discussion with your doctor really is not to go in and ask about pain meds. You got to go in and instead talk about functionality. The best workaround is to walk into your doctor and sit down and say, listen, doctor, I am so uncomfortable that I can't sit in a car and drive to work. I cannot sit through the day at work. I cannot make dinner. I cannot go to church. I cannot clean my house. What can we do to restore my functionality. And if you focus it that way and say, what can we do so that I can sit more comfortably? That opens the door for them to go, maybe we should consider some pain medicine for you in this circumstance, right? But if you go in and you ask for pain care, you're going to look like a drug seeker. You know, literally, I chaired the state of California pain conference like 15 years ago, and it led to our governor signing the Pain Patients Bill of Rights. It was really, really big. And I worked with the Bureau of Narcotics Enforcement, and we brought all the head of the Bureau of Narcotics Enforcement here in California was actually a prostate pain patient. It was great. I mean, we had a really, really good discussion. So, literally, I have all these experts who flew in that day, right, for the next day. And I go to Kaiser to pick up my once a year 20 Vicodin, 20 Norcos, or whatever they were. And the guy who gave me it at my pharmacy basically threw it at me and said, well, I guess we'll know if you're an addict if you're back in a week. And I went, what? And he was just very, very snarky. And so I drove home furious. And I called the manager of the pharmacy and told him what happened and said, this is completely unacceptable. And then I opened the entire conference with that story and say, well, this just happened to me yesterday. So anyway, opiates are challenging. They're the best. They can be the best for dealing with our type of pain. Now, also, there is some pain in some people that opiates don't work well in. I was working with a patient on Friday who literally opiates didn't touch her pain at all. And that's when a benzodiazepine might be helpful, something like Xanax. You never know. Sometimes that actually helps to reduce pain in some patients. It's a very complex situation. Anyway, I've written extensively about this in our magazine. I've written big articles on the history of the CDC guidelines and how that's affected all of our ability to get pain care. And the only other thing I can just say is if you're having a root canal or something like that, and they offer you pain meds, I personally, I wouldn't turn them down. I don't want to get in trouble for saying that, but oh, I don't know. You know what I mean. Do you know what I mean? Do you understand what I'm saying here? Maybe, kind of, sort of. I didn't say that well. Let's just say for me personally, I use the least that I can use. I use the least that I can use, the lowest dose that I can use, so that I might always have a little bit just in case something happens. Oh, I don't like the way I'm saying that. Shoot. But I don't know how to say it better. Sorry. I hope you understand what I'm trying to say. Be honest with your doctor about your needs. Talk about functionality. And let's go from there. I will say this. If I had a doctor who wanted to do an aggressive, and like when I had my DNC, I flat out said, I refuse to do this unless I have pain care, period. End of story. Will not do it. And he's like, fine, we'll give it to you at the hospital. And I went like, no, I'm not falling for that. I want a prescription in my hand right now. I want to have it filled and at home so that when I come back from the hospital, it's there in my bedroom ready to go. And he was fine. He's like, not a problem. And he gave it to me and I had it filled and we were fine. I don't know. I just don't, I don't trust the outpatient discharge process to be receptive to pain needs now. I don't. What Boreas says, what about CBD? I think CBD is great. If CBD works for you, power to you. If you have a dispensary near you, you go down, you remember it's a medical marijuana or a hemp. It needs to be very high in CBD, not THC. And the bladder does have cannabinoid receptors in it. In fact, there was a research team in Detroit who were studying a medical marijuana-derived bladder installation. I don't know what happened to that. They kind of fell off the face of the earth. But the bladder does have cannabinoid receptors in it. And so it would be reasonable to try CBD. Oh, God, I hate it when I get awkward with my words. That was awkward. Sorry about that. Let me tell you, I want to give you another case study, okay? Okay, Bruce's story. Bruce came to our center at the age of 57 with a 1.5-year history of rectal burning. Initially, he attributed the problem to hemorrhoids associated with a history of straining to have bowel movements. But when hydrocortisone cream did not help, he was afraid that he might have cancer. His symptoms had progressed to the point where he was experiencing severe pain after bowel movements that felt like, quote, the flesh was being torn on the inside. This problem limited his movement, making it impossible to walk or sit for any length of time, and the pain intensified if he drove his car for more than a couple of hours. He also reported that when he sat on a hard chair, he experienced numbness in his perineum and tingling in the head of his penis. Further, he had a weak urinary stream, a burning sensation when he started or stopped voiding, and some discomfort with orgasm. These symptoms prompted his primary care physician to diagnose prostatitis. But when antibiotics produced no response, Bruce was referred to a colorectal surgeon who diagnosed levator ani syndrome which is tight levator ani muscles, right? Finally, his primary care provider prescribed Valium to relax the anal muscles. This provided sufficient release to allow him to function. However, to maintain a positive effect, he had to keep increasing the dose, and then side effects began a problem. When I performed the pelvic floor muscle examination, I found trigger points in the puborectalis, anal sphincter, and urogenital diaphragm. There was also marked sensitivity of the left pudendal nerve. Following internal myofascial release to diffuse the trigger points, there was, as I had anticipated, a significant reduction in muscle tenderness and nerve sensitivity. At the time of Bruce's second visit, he reported a greatly reduced level of pain, and my examination revealed trigger point tenderness to be only mild to moderate and nerve sensitivity to be gone. Bruce continued to do well until he had a colonoscopy, which produced a flare of rectal pain. I found that the procedure had activated trigger points in his puborectalis muscle, which I then injected with an anesthetic agent. This single treatment promptly relieved his anal pain, and it has not returned since. Bruce expressed deep appreciation, telling me that he had been pain-free for the first time in a 1.5 years. So how do we put this info together? Well, Bruce's medical history had applied an important clue to his present symptoms. In 1995, while moving a refrigerator, he fell down a flight of stairs and injured his tailbone. Over the next 2 months, the pain was so severe and walking so difficult, he required bed rest. The tailbone injury had acutely overstretched the attaching muscles. Unfortunately, one of these is a segment of the pubococcygeus muscle called the puborectalis. The puborectalis surrounds the anus and rectum, anyway, we don't have to do that. Okay. While many knowledgeable practitioners would tell you we don't know exactly why this contraction of the puborectalis occurs, pain can certainly play a role. What's important to remember here is that trigger points seldom go away unless they are eradicated with appropriate treatment. Though they may no longer be causing pain, another nudge is all it takes to reactivate them and cause a symptom flare anywhere along the muscle route. In this case, all that was required to set the pain train in motion was another trauma to the muscle, from something as simple as straining to have a bowel movement. You know, Brianna says, is there a way to watch these once you aren't live? Yeah, honey, they're all recorded on the Facebook page and on the YouTube channel too. They are all recorded. Let me see if I have. Here we go. What is this one? Hold on a sec. Let me do a Vulvodynia one. Okay, so let's do a case study of Vulvodynia, okay? And then we'll do another one on IC. When Peggy arrived at our clinic, she was 38 years old with a 4-year history of vulvar pain. She was an avid mountain biker and recollected that before the pain had become a serious problem, she had been experiencing discomfort from her bicycle seat. This had prompted her to switch to a seat with a cutout center. Her vulvar pain began immediately after she slipped and fell on her son's skateboard. At that instant, she experienced severe burning pain like a fire that started in her left labia and spread around the right vaginal opening. She ran to her gynecologist, who saw absolutely no abnormalities. However, in case there was a problem that he couldn't see, he performed punch biopsies. The biopsies confirmed that the tissues were normal. Then, just in case there might be an infection he couldn't detect, he prescribed an antibacterial vaginal jelly. Not only was there no relief, but the symptoms increased and began to spread. Peggy developed continuous pain in her tailbone that escalated if she sat for more than 20 minutes or drove for more than 10 minutes. Her only reprieve came when she sat on a donut cushion that protected this sensitive area. And as time passed, she also began to experience very annoying symptoms of urinary frequency, for which she consulted a urologist. He examined her bladder with a cystoscope. When the bladder looked entirely normal, he was stumped with no treatment options suggested. Peggy's frequent urination continued and the vaginal burning intensified, making sex extremely uncomfortable. So she returned to the gynecologist, who prescribed topical vaginal estrogen and a powerful steroid cream, both of which increased her vaginal pain. Finally, perhaps out of frustration and a lingering concern that there might be a hidden resistant yeast infection, he treated her with Sporanox, a high-potency oral antifungal medication. But after 2 months on the drug with no signs of improvement, she consulted me. And this is Dr. Jerome Weiss. Okay. By the time I saw Peggy, she had a history of tailbone, urinary frequency, labial pain, and vaginal burning, was no longer able to have sex. As yet, no treatment had helped because nobody had connected the dots. Upon examining Peggy, I found subcutaneous tissue of the lower abdomen and inner thighs to be very sensitive. The skin on the left side of her rectum to be very painful when lightly touched with a needle, and the internal muscles on the left side of the pelvic floor to have active, very tender trigger points. But the most impressive finding was marked sensitivity of the left pudendal nerve. An anesthetic block of this nerve abruptly alleviated Peggy's pain and confirmed that a nerve injury was the cause of her symptoms. The diagnosis was pudendal neuralgia, also known as IC subtype 4. Remember, positional pain. You're fine when you stand, but when you sit down, it hurts, or when you bend over, it hurts. Reviewing Peggy's past history, it is easy to detect the sequence of events that culminated in pudendal neuralgia, which in turn produced urinary and vulvar problems. She was a mountain biker who had noticed tailbone pain from an uncomfortable seat, indicative of trauma to the pudendal nerve. That injury remained only mildly symptomatic, yet left the nerve more vulnerable to subsequent injury, which occurred when she slipped on a skateboard. This severely stretched the nerve, producing pain in the vulvar tissues that the nerve innervates. Pudendal nerve injury commonly refers pain to the tailbone, pain which became constant in Peggy's case, with severe flares when she sat for more than 10 or 20 minutes. And because the pudendal nerve also supplies the urinary sphincter, Peggy developed urinary frequency with a burning sensation if she held her urine too long. She even noted pain in the back of the left thigh and tingling in her toes. This could have been related to the spasm of piriformis muscle through which fibers of the pudendal nerve travel within the pelvis. Since she lived outside the area, Peggy was referred to a physical therapist in the city where she resided for continuing care. It was suggested that further treatment of pelvic floor muscle trigger points, sub-Q tissue sensitivity and restrictions, and the nerve itself would probably be necessary for durable relief, but at least an accurate diagnosis had been established. The failure to consider the history of a stretch injury preceding labial pain and not including pudendal nerve examination as part of the initial evaluation had caused the suffering woman to undergo vulvar biopsies, multiple courses of topical antifungal hormonal steroid creams, 2 months of Sporanox, a cystoscope, and a neurological consultation. Peggy's story points out the need to view vulvodynia from a broad perspective. It is so important that we spend the time required to determine whether all of the patient's symptoms are interrelated and fit under one diagnosis, in this case, pudendal neuralgia, et cetera, et cetera. It is also important to remember that chronic unexplained vulvar pain doesn't always signify the presence of a yeast infection. It takes very little time to prescribe an antifungal med. It takes a lot more time to do the detective work required for a correct diagnosis. And he says here, I should mention that clitoral pain is also commonly related to an injured pudendal nerve and can frequently be alleviated with one or more nerve blocks. Okay. So anyway, and let me just do one. I want to do an IC, couple of IC case studies here. Oh, how you guys feeling? It's May, guys. It's May. It reminds me of that wonderful song in Camelot. It's May, the lusty month of May. And I forget the next word. Tra-la, it's here, that lovely time of year. It's May. Winter is officially over, right? I hope so. All right. Esther's story. Esther came to me with a 12-year history of increasing urgency frequency. A previous physician had made a diagnosis of IC with a hydrodistension of the bladder. She was then treated with 3 subsequent hydrodistensions and bladder installations of DMSO, lidocaine, heparin, and cortisone. None of these therapies gave her significant or sustained relief. Then she developed severe burning pain in the vulva and inner thighs, making it difficult to walk or sit. When I examined Esther, I found trigger points in pelvic floor muscles in the urinary sphincter, as well as marked sensitivity and restrictions in the subcutaneous tissue over the pubic bone and lower abdomen. Another major finding was marked trigger point sensitivity in the rectus abdominis muscles of the lower abdomen. I treated Esther initially with internal and external myofascial release, which decreased her pain with sitting, but still her urinary symptoms flared. I then revised her therapy to include trigger point injections into the rectus abdominis, followed by an anesthetic infiltration into the hypersensitive subcutaneous issue of the pubic region. After several months of this regimen, her abdominal wall returned to normal without any trigger points or tissue sensitivity. Along with these changes came a dramatic shift in her symptoms. She experienced no pain and less frequency, with a dramatic decrease in urination at night from every 30 to 60 minutes to only 2 or 3 times. Esther's story illustrates what can be accomplished when one thinks outside of the box, or in this case, outside of the bladder. That is our theme. That, my friends, is our theme. Here's another one. Oh gosh, there's a whole bunch. I got to take a drive up to the IC Network warehouse when we're done, because somebody accidentally shipped some product to my house and I got to get it up there. So we'll probably go for another 20 minutes or so. Kira says, Kira came to me at the age of 34 complaining that for about a year she'd been urinating every 1.5 to 2 hours during the day and 2 times at night. Though considered symptomatic, this frequency is moderate relative to what many patients have experienced. What made it intolerable was the intense bladder and lower abdominal pain, 8 on a scale of 10, that accompanied the urination and lasted for about an hour. Prior to the onset of these symptoms, she had occasionally gone up to 12 hours without voiding and experienced no problems. Kira's history included many musculoskeletal issues dating back to high school when she was involved in a car accident. Low back pain began at the age of 21, requiring periodic adjustments. Her neck also, quote, went out just before urinary symptoms began. Upon examining her, I found 3 clinical signs for pudendal nerve irritation or injury. These were sensitivity to skin rolling and pinprick tests around the perineum and sit bones, and exquisite bilateral nerve sensitivity when touched internally. In addition, the muscles of the entire pelvic floor and perineum were tight and loaded with trigger points. There were also internal trigger points in the hip rotators, which, as I explained, can directly compress the pudendal nerve. Internal myofascial release performed at the time of my internal exam relaxed the muscles around the nerve. This almost completely cleared the skin and nerve sensitivity. Just that one treatment gave Kira dramatic relief in terms of frequency and pain. After 3 treatments, the nerve sensitivity to touch was diminished over 50%, and she was able to sleep 7 hours without voiding, and the urinary urgency and pain were gone. Then, to reduce the tension around the pudendal nerves, I performed bilateral trigger point injections. After 2 months of treatment, the dysfunctional pelvic floor, perineal, and external hip rotator muscles had normalized, and the pudendal nerve had calmed down completely. Since then, Kira has continued to do well. This young woman was lucky to have received appropriate treatment for her pudendal neuralgia and associated muscle dysfunction within a year of following the onset of her symptoms. Most patients suffer far longer than that before the cause of their problem is finally identified. As I emphasized in chapters 5 and 10, if a nerve injury is allowed to persist for an extended period of time, it can take a longer time to fully resolve. Okay? So anyway, I hope you're getting my point here. We're looking beyond the bladder. Beyond the bladder, my friends. Elena, thank you so much for the 100 stars. Very, very much appreciated. Thank you so much. All right, guys, any more questions? Go ahead and hit me with your questions. Give me a hard one. Give me an embarrassing one. Give me one that you would never ask anybody else. I'm willing to take the most embarrassing question you have to offer. And I won't even repeat your name if you ask them. Last call for questions. Last call for questions. So this week, I can tell you that we are finishing our new diet project. The typesetter is working on that right now. Hopefully I will have a new flare management guide for you, new diet guide for you. Our spring IC Optimist is in the works right now, slowly. I want to have it done by the end of this month. We'll see. I'm always a little late. You know, things are crazy. AUA meeting is next week, so we'll have some brand new research to talk about. That'll be very exciting. What else do I have in the works? And we're getting ready, IC Awareness Month in September. If there's anybody out there who wants to be involved in IC awareness, you know, guys, I have to step back in the fall now. I just can't do a lot because of fire season, right? So I have not been able to do hardly anything for IC Awareness Month in the last 2 to 3 years. And so if there's anybody out there who feels like they want to be involved in the planning of IC Awareness Month, please reach out to me because we need help. All right. All right. Well, I guess we don't have any more questions, so I'm going to call it here because I got to hit the road. I will see you guys later. Y'all have a wonderful evening. Remember your homework. Number 1, you've got to do some 15 minutes a day for your spirit or soul, something that will give you comfort for 15 minutes a day. I need you to do something for your pelvic floor and or your bladder. For 15 minutes a day, I need you to read something. Let's improve your knowledge level out there. You have done that today by attending this meeting. And then last but not least, I need you to laugh, because when you laugh, your brain modulates pain and reduces the intensity. Pain that accompanied by anxiety and tears is intensified because your brain thinks your life is at stake. Pain that is accompanied by laughter is minimized because you're laughing, therefore your life can't be at stake. So please try to do things that make you laugh as much as possible. And I know it, I know it's hard. I mean, we all go through periods where we're frustrated and lonely. And yesterday was a very lonely day for me. It's something that I just struggle with. I want to have more people in my day-to-day life, and it's very hard not to have more people. I wish you were here in Santa Rosa so that we could hang out and do stuff. Wouldn't that be great? Even if we just met for lunch or dinner once a month. But man, I want to go do things. I want to go do more. And it's just COVID and all that sort of stuff is really, it's been hard. It's been hard for us. We're kind of stuck at home right now. And yes, things are getting better, but I'm certainly not quite ready to go out into a large crowd without a mask. That's for sure. So, all right, guys, I'll see you later. Have a good one. Bye, YouTube.